Hypoxic Pulmonary Vasoconstriction, Pathophysiology, Diagnosis, and Evidence-Based Management. Hypoxic pulmonary vasoconstriction, HPV, contributes to greater than 30% of morbidity in high-altitude exposure, chronic obstructive lung disease, and acute respiratory distress syndrome. The reflex is mediated by alveolar O2 tension less than 60 mm of mercury, leading to calcium-dependent smooth muscle contraction via endothelin 1 and Rho kinase pathways. Diagnosis hinges on right heart catheterization showing mean pulmonary artery pressure greater than 20 mm of mercury with pulmonary vascular resistance greater than or equal to 2 Wood units and a normal pulmonary capillary wedge pressure less than or equal to 15 mm of mercury. First-line therapy combines inhaled nitric oxide, 20 ppm, with oral phosphodiesterase 5 inhibition, sildenafil 20 mg TID, while long-term disease control follows ESC/ERS 2022 pulmonary hypertension guidelines. Key points. Note: HPV is triggered when alveolar PO2 falls below 60 mm of mercury, producing a 2 to 3-fold increase in pulmonary arterial tone within 10 seconds, median onset 8s. In healthy adults, mean pulmonary artery pressure, MPAP, rises from 14 plus or minus 3 mm of mercury to 22 plus or minus 4 mm of mercury during acute hypoxia. FiO2 equals 0.10. Right heart catheterization defines hypoxic pulmonary hypertension, HPH, as MPAP greater than 20 mm of mercury, pulmonary vascular resistance, PVR, greater than or equal to 2 Wood units, and pulmonary capillary wedge pressure, PCWP, less than or equal to 15 mm of mercury. In high-altitude pulmonary edema, HAPE, the incidence is 0.2%, 0.5% above 4,500 m, with a case fatality rate of 10% without treatment. In COPD, the prevalence of HPV-related PH is 25% in Gold Stage 3 and 38% in Gold Stage 4 patients. Inhaled nitric oxide, ENO, at 20 ppm improves oxygenation by 12% plus or minus 4%, PO2/FiO2 ratio, within 30 minutes. DOS escalation to 40 ppm yields an additional 5% plus or minus 2% gain. Sildenafil 20 mg orally 3 times daily reduces PVR by 30% plus or minus 6% after 4 weeks, P less than 0.001, and improves 6-minute walk distance, 6 mWd, by 45 m plus or minus 12 m. Bosentan 125 mg orally twice daily lowers MPAP by 8 mm of mercury, 95% CI610, after 12 weeks. Liver function monitoring is required every 2 weeks for the first 3 months. The ESC/ERS 2022 guideline recommends initial combination therapy, endothelin receptor antagonist plus phosphodiesterase 5 inhibitor, for WHO Group 1 PAH with a Class 1, Level A recommendation. Right ventricular, RV, failure develops in 32% of patients with chronic HPV, and 1-year mortality rises to 27% when RV ejection fraction falls below 35%. Overview and epidemiology. Hypoxic pulmonary vasoconstriction, HPV, is a physiologic reflex that redirects blood flow from poorly ventilated alveoli to better ventilated regions, preserving ventilation perfusion, V/Q, matching. When the stimulus is sustained, the reflex becomes maladaptive, leading to hypoxic pulmonary hypertension, HPH. The International Classification of Diseases, 10th revision, ICD-10, code for pulmonary hypertension due to lung disease and hypoxia is I-27.0. Globally, an estimated 2.5 million individuals develop clinically significant HPH each year, is almost equal to 0.03% of the world population. In the United States, the prevalence of HPV-related PH among patients with chronic obstructive pulmonary disease, COPD, is 28%, is almost equal to 1.1 million. Based on the National Health and Nutrition Examination Survey 2017-2020. In the Andean high-altitude regions, greater than 3,500 m, The prevalence of HAPE is 0.2%, 0.5% per ascent season, translating to is almost equal to 12,000 cases annually. Pathophysiology. HPV initiates when alveolar PO2 falls below the threshold of 60 mm of mercury, sensed by pulmonary arterial smooth muscle cells, PASMs, via oxygen-sensitive potassium, K, channels, Kv 1.5, Kv 2.1. Hypoxia inhibits these channels, causing membrane depolarization, opening of voltage-gated L-type calcium channels, and a rise in intracellular Ca superscript 2 from a baseline of 100 nanomolars to 250300 nm within 5 seconds. The calcium surge activates myosin light chain kinase, MLCK, leading to actin-myosin crossbridge formation and vasoconstriction. Endothelin 1, ET1, expression is upregulated by hypoxia-inducible factor 1 alpha, HIF1 alpha, increasing plasma ET1 concentrations from a normal 1.5 pg/ml to 5.2 pg/ml, mean plus or minus SD, after 24 hours of sustained hypoxia, FiO2 equals 0.12. ET1 binds endothelin A receptors, ETA, on PASMs, activating the RHOA/rhokinase, ROC, pathway, which phosphorylates myosin light chain phosphatase, MLCP, and sustains contraction independent of calcium. Calcium sensitization. Key points: right ventricle, chronic pressure overload leads to concentric hypertrophy, RV wall thickness 30% after 12 months, and eventual dilatation. RV end diastolic volume index greater than 120 milliliters per square meter. Lungs, persistent vasoconstriction promotes vascular remodeling, with medial hypertrophy, intimal thickness 45% at 6 months, and adventitial fibrosis. Kidneys, elevated PVR reduces renal perfusion, causing a 12% decline in glomerular filtration rate, GFR, over 2 years in severe HPH cohorts. Clinical presentation. The classic presentation of HPV-related PH includes progressive dyspnea on exertion, DOE, in 84% of patients, non-productive cough in 46%, and fatigue in 38%. In high-altitude HAPE, acute onset of dyspnea, frothy sputum, and peripheral edema occurs within 2-5 days of ascent, with a prevalence of 0.2%, 0.5% among trekkers above 4,500 m. Atypical presentations are common in elderly patients, greater than 70 Y, with comorbid COPD, 27% present with isolated orthopnea, and 19% report nocturnal dyspnea without daytime symptoms. Diabetic patients may manifest silent RV failure, with only a 12% incidence of peripheral edema despite RV ejection fraction less than 35%. Immunocompromised hosts, e.g., post-transplant, can develop HPV-induced PH without overt hypoxemia, presenting instead with unexplained tachycardia, HR greater than 110 bpm, in 22% of cases. Key points: loud P2, sensitivity equals 78%, specificity equals 71% for MPAP greater than 20 mm of mercury. Right-sided S3 gallop, sensitivity equals 64%, specificity equals 85% for RV dysfunction. Peripheral edema, ankle swelling greater than 1 cm, sensitivity equals 55%, specificity equals 90% for advanced PH, WHO FC34. Diagnosis. A stepwise algorithm is recommended, Figure 1, not shown. 1. Initial screening key points, pulse oximetry, SpO2 less than 92% on room air prompts further evaluation, positive likelihood ratio is almost equal to 4.2. NT-proBNP, value greater than 300 pg/ml, sensitivity equals 85%, specificity equals 78%, suggests RV strain. Tricuspid regurgitation, TR, velocity greater than 2.8 meters per second, estimated systolic PAP greater than 36 mm of mercury, yields a diagnostic odds ratio equals 6.5. RV basal diameter greater than 42 mm, sensitivity equals 71%, and taps less than 16 mm, specificity equals 84%, support pH suspicion. References. 1. Herrera E.A. et al. Long-lasting cardiovascular responses to gestation at high altitude, lessons from a sheep model. Philosophical Transactions of the Royal Society of London. Series B, Biological Sciences. 2025, 380, 1933-20240182. PMID, 408368817. https://pubmed.ncbi.nlm.nih.gov/408368817. DOI 10.1098/RSTB.2024.0182. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.